Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So what we're going to talk about today actually is tumour dynamics in patients with solid tumours treated with pembrolizumab beyond disease progression. Actually, I think a nice paper from Cancer Cell last year, and probably a few issues coming out of that which are worth thinking about. But before we do that, you get to have the icebreaker question about emergencies on planes or in other situations where they say, is there a doctor on board? And before you do that, I forgot to say last time, I didn't tell you, because I was only 24, 25, that story going to Cape Town. So I put up my hand when they say, is there a doctor on the plane? And they come over and say, oh, hello, sir, would you like another drink? Because they actually didn't believe I was a doctor. Anyway.
Well, I do have a few. I mean, this is sort of like you have so many. It's like, which one do I tell you? I'll tell you about the first, one of the first, and then a non-in-flight emergency, same as yours, blood everywhere. I mean, very quickly, I went to New York for a trip. On the way back, this is New York to Houston. We're massively delayed, so that's already factoring into the flight crew's thinking at the time that we end up with a medical emergency on board. We're massively delayed. I'm flying economy, somewhere towards the back of the plane, and there's an entire high school or junior high volleyball team that wants to board, and you can recognize a volleyball team because they're a bunch of young women, many of them in their cute little volleyball shorts and some with their knee pads on for some reason, because it's easier to wear them than to pack them. And every single one of them is carrying their pillow from home. So it's like 15 or 20 young women with their pillows, with knee pads and their shorts, and some, female chaperones scattered here and there. And we eventually all board the plane, and I'm seated next to one of these young volleyball players and their mother or their chaperone. And we get to chatting, and I say, oh, I'm a doctor, this, that, and the other. Oh, that's cool, whatever. Slink into the seat. It's probably 3.5, 4 hours to Houston. We're massively delayed. We're probably 2 to 4 hours delayed. Maybe not massively, but enough that it's, they're already talking about people who will miss a connection in Houston. And then there's a medical emergency on board. They make the announcement. I think it must not have been my first one because my instinct was not to react. It was to hold tight. I'm very slow. I sort of have a delay. There's always a confident white man doctor on a plane, just turns out. No disrespect, James. There's always a confident white 25-year-old doctor on the plane. 30-year-old me at the time did not need to respond. And I must have known at that point how ill-equipped we were, on these flights. So I don't respond. I don't say anything. And of course, the 14-year-old turns to me and says, aren't you a doctor? And I said, oh, yes, yes, yes. And so I put my hand up, ring the buzzer. They come. Turns out the guy that was having an emergency, so I was middle section aisle seat. He was the other section, left-hand section, in a two-person, him and his wife, and he was just a row or two in front or behind me. So I was quite close to him. So I go over. It's an older gentleman in his 70s or 80s. They've just done a big return flight from Rome to New York. New York to Houston will be their final. He's having chest pain. He's short of breath. His legs are swollen. I said, how long was that flight, Rome to Houston? Oh, 8 hours. And I said, did you get up on that plane and walk around periodically? He didn't get up on that flight. So immediately, and he's having chest pain and he's visibly dyspneic. I mean, he is really not doing that great. So I said to the flight crew, I said, he doesn't look great to me. What would it take to land, wherever we are, what would it take to land this plane? Well, let's call MedLink down at the ground. Let's find out. Of course, they come back up and say, what are his vital signs? because the vital signs are everything, right? So they give me a spig and everything, and I check in, and his vitals are okay. I mean, he's oxygenating decently, or, low 90s, high mid 90s. Blood pressure and heart rate are okay. So, of course, even though I'm not having a good feeling about this guy, they're saying, well, MedLink crew says vital signs are stable, keep going. We can't land the plane for this. And what's playing into their head is we're already delayed. So I said, okay, well, I think he needs aspirin. At minimum, I think he needs aspirin. He's either having a heart attack, a PE, something bad is happening. So so they bring me the kit. Let's see what's in it. So they bring me a blister pack of aspirin, and I turn it over first to look at the expiration date, as you do with meds and condoms and milk and other things. And then I also looked at the strength, right, on this aspirin thing. And it said, what did it say? I'm just trying to think of it. I think it said 50 grains. Grains, Grains, exactly my reaction. Grains? Is this aspirin from the fucking Middle Ages? what are we measuring in grains of sand? What on earth? How much is 50 grains? And this legitimately was pre-widespread, smartphone use. I mean, this was post 2008, but not that much post 2008. So how much is 50 grains? I mean, I really have no idea. So ultimately, there were 2 aspirin in this blister pack. So I said, well, take them both. I don't remember if I told him to chew it or not. He takes them both. He's not that much better. We have 2 hours to go. I, kind of like you, then kind of move seats to be near him to just sort of check in every 15 minutes. I don't do obs on him that often, but because at this point it's clear I'm not in charge here. The ground medical team is in charge. I said, listen, I think you just need to go straight to an emergency room. Do you know where the closest one is? Yes, yes, yes. And I called them a couple of days later, and she says, oh, and I say, I'm the doctor that helped you on the plane. Oh, yes, sweetie, we're still in the hospital. And I said, oh, yeah, what did they say is going on? Was it your husband's heart? No, they said his heart was fine. And I said, okay, well, what did they say? And she said, well, he's gotten several blood transfusions. They said he had a large bleeding ulcer in his stomach. And I said, oh, lovely. So anyway, I very quickly was like, okay, well, sounds like you're in good hands. Be well, take care, bye, and hang up. And I thought, oh my goodness. But back in the day, this was Continental Airlines. And after that one that I helped this gentleman, they gave me 30,000 miles for that. I'll never forget the letter I got. This is, we dumped 30,000 miles, which is enough for a ticket back then in the US, a round trip ticket. And then for all the ones I've responded to after that, you get nothing. I mean, absolutely nothing. We've talked about this. You get 0. And then I had an episode where I was on a date with a guy in Denver. Yeah, it was in Denver now that I'm thinking about it. We go to a bar and the bar's pretty empty and we're ordering something. And then we hear this massive crash of glasses. There's a bit of a pause. And then a screeching scream comes out. And the bartender has fallen behind the bar with all the glassware and sliced, and she has an arterial bleed across her wrist. And I have this fantastic kind of half leather jacket that I had just bought, that I could barely afford at the time. Had on a great pair of jeans, a great blouse underneath. Yeah. And I was like, oh, for God's sake. So I do like a move where I take off the jacket because I'm not getting that thing bloody. And I go around and I just put my hands over her hands and it's just gushing blood. And I get all the they had cloth napkins at this place, and I fashion a tourniquet, kind of like a round, double. I went high, but I did it lower than that. Meanwhile, I'm like, can somebody please call 911? And then by the time ambulance comes and they're like, hey, good job controlling the bleed. I said, I tied it as tight as I could. I did my best. Put a pen in there to sort of tighten the tourniquet, and then went to the bathroom. At this point, a lot of her blood has dried on me. It's dried down my arm. It's dried under my fingernails. So I spend a fair amount of time in the bathroom cleaning up. But then, of course, I come out and the guy's like, let's go home immediately. I was like, I'm fine. We can stay and drink. He's like, I'm so fucking turned on right now. It's like, okay. Anyway, so a few of these. That's my 10-minute story on.
Do you think the second one's going to make the editing cut or not? We'll have to wait and see. But anyway, at least the first guy was okay. With the aspirin,
Yeah.
and all's
Yeah,
well that
I
ends
know.
well. Okay, so shall I just say what the title of this paper is? I've done that already. It was in Cancer Cell 2023, and the lead author's Brian Topp from Merck, and then Jed Wolchok and Tony Rebus are the senior authors, or Tony's the senior author, and actually Alex Snyder, who used to be at Memorial, now at Merck, I think, who I used to know a little bit when she was at Memorial, is also an author here. So maybe to introduce it a little bit, there's this whole question of treatment beyond progression with checkpoint inhibitors. And there
Do you do
are
that
some...
in practice? Do you treat beyond progression in practice?
Yeah, absolutely. And we've talked about this before. So, if I've got someone especially if they're on their first scan, they're clinically well, they're tolerating treatment well, they don't have what you might call anatomically critical sites of disease, so you can afford to wait a little bit longer. And I think the scan is a bit mixed. Well, let's just carry on for another scan, see what happens. It feels like, there might be some benefit here. And I just think the obvious comment is that RECIST, even modified RECIST, is quite a blunt tool here for trying to work out if these treatments are helping or not. But go on.
Did you do that in the chemotherapy days? Did you treat people beyond progression with dacarbazine, or were you ever a high dose IL-2 or biochemo placed?
No, we never really. We did a little bit of sort of high dose IL-2, but I was a very junior doctor then, so I was just looking after the patients on the wards who were having side effects. I wasn't making any decisions about carrying on treatment or not.
You're experienced enough to have used dacarbazine now.
Yeah, absolutely. Well, what's to say? Yeah, so when I started as a consultant in 2008, that was pretty much still standard of care, or a standard of care, whether you like it or not, for metastatic melanoma. So the trials had it as the control arm in the main then. Even Checkmate 37 and some subsequent trials, we know this anyway, even recent trials have had cytotoxic chemotherapy as a control arm option. I was thinking about tebentafusp trial. There were some patients on the control arm of that who had cytotoxic chemotherapy, right, from memory. Pembro was, mostly a bit of IPI, and I think there was a bit of chemo. Anyway,
Yeah, you're right.
Did I treat beyond progression there? Not really. I think if you had a view of the disease trajectory, and that's an important thing as well. In other words, what did things look like prior to starting treatment? And you thought there was some impact on the natural history of the disease. Yes, I might, with all the same sorts of caveats. But before I stop, I'll just say another massive question here, which will vary from patient to patient, is if you stop this treatment, what are your other options?
Well, that was what I was going to say. The only reason we would have treated past progression back then is because they're doing okay on it. The burden of their cancer is not so imminently fatal, and we had nothing else. So treatment beyond progression in chemotherapy is not the same as treatment beyond progression here. We're using a different part of our decision making for that. The reason we did it back then is because of options. If people are listening who treat other cancer types, the reason you might treat beyond progression in chemo or targeted therapy, again, is different. Maybe it's not an options issue, but it's what does the disease look like, trajectory, and in some cases, maybe it is, in pancreas cancer or other things. What else do I have? Uveal melanoma is a nice example. But the truth is, that's not what we're talking about here. Treatment beyond progression with this immunotherapy and these keynote studies that they looked at specifically was more of, it's more of a referendum on the failure of RECIST to tell us accurately what's happening or to tell us about somebody's immune response that can take, what do we often say, 6 or 12 weeks to generate benefit.
Absolutely. And, it all comes back to RECIST having been developed originally, at least in the days where cytotoxic chemotherapy was the main modality that we used to treat solid tumours. And I suppose the other obvious comment is that what we want to do here with our treatments is prolong survival. And so if we've got a treatment that we think is having some benefit, and some of this is going to be quite end of the bed stuff, as we would say. And the other expression that I might use is you don't want to throw the baby out with the bathwater, because to some extent it can be very easy to stop treatment and prescribe another treatment, certainly if you've got another treatment which you know is active. But quite often that might not be the right thing to do. So anyway, I guess just some top line stuff, maybe. It's a mixture, as you say, from Keynote trials, almost 800 patients, 176 melanoma, 146 non-small cell lung cancer, 87 gastric, 112 head and neck, 51 renal cell carcinoma, 227 urothelial carcinoma. And so basically these were patients who were treated beyond RECIST-defined progression in clinical trials, but had the opportunity to carry on with treatment, depending on the protocol, I suppose, for what was viewed by investigators as potentially deriving clinical benefit, which is a relatively common, clause, shall we say, in clinical trials. And then the question is, what happens in this selected group of patients when you treat beyond progression? Maybe I'll go over to you now, because I reckon I've been talking too much, at least in the non-medical emergency segment.
No, you've talked a very small amount so far. So, actually the denominator of the trials is even larger than that 800. So because the melanoma one specifically, if we just parse out the melanoma cohort, it was 313 patients from the Keynote 001 trial who had progression of disease. And as you say, 176 were treated beyond progression, which is to say they just continued the treatment. They didn't, and Keynote 001, for those who don't know, was pembro at different dosing schedules, but no comparator arms. There was no control arm, if you will. Our first experience with the drug, it was lambrolizumab, is that publication actually. And it was one of our first experiences where we got an FDA approval based on a non-randomized result that needed a confirmatory phase 3. This is just sort of FDA's model now that they're offering. But of these 176 patients, 43 of them, 25%, basically had reduction in their target lesions. Clinically meaningful, defined as greater than or equal to 30% reduction in their target lesions. But if you took this structured RECIST criteria and applied them to those same 43 patients, 25% of that treated beyond progression cohort, RECIST fails you here, because objective RECIST responses are only happening in, what does that table 1 say, 8.6%, whereas clinically meaningful reduction in target lesions, 30% or more reduction, was happening in a quarter of these patients. RECIST is only saying objective response in 8.6, and why is that? Because as you and I know, progression of disease in RECIST is the appearance of new lesions. So even though they had some target lesions that were reducing by 30%, they might have had a dot or here or two or multiple show up. And when you clinically have that patient in front of you in the real world, and you see existing tumors are shrinking, but there are some new tumors developing, what does your gut tell you? Is that a patient who's having a favorable response or unfavorable response?
Yeah, I mean, that's not even a question really to me. I mean, generally that's going to be a favorable response. And then I immediately start thinking to myself, other things being equal, well, we should try and carry on this treatment if we can. And should we be thinking about some local regional treatment for the progressive site? And so then, without wishing to go into it too much, you've got the whole thing about what is oligoprogression, how do you deal with it? And we've talked about that before, and we've published our series of what you might call oligoprogression. And again, this is all selection and everything else, but I think we all know anyway from clinical practice, if you some of those patients, you deal with one or two sites of progression in the face of otherwise generalized response, they will do very well in the long term. So maybe, that's something to bear in mind.
Okay, let's circle back to that point maybe as we end this, about what that means when we're thinking about trials that are looking for a signal in this population of treatment beyond progression or PD-1 refractory. I mean, that's where this ends us, is that treatment beyond progression is potentially thinking about a PD-1 refractory population, but already here we see a quarter of patients are getting clinically meaningful benefit, continuing on exactly with what they were getting, PD-1 based therapy or PD-1 monotherapy in this case. So is that really a PD-1 refractory population just because they had progression on a scan, RECIST, blunt tool here? Or is it PD-1 experienced? And refractory, of course, is maybe not the term we want to use. So that's, we'll circle back there. But I guess what I like is the idea of what we should think about potentially is how were they doing as we first administered the treatment, and how are they doing after we administer treatment beyond progression. And these authors describe it as grow, grow, stable, stable, shrink, shrink. I kind of like that. But there are patients who had progression of disease, after, so this is treatment beyond progression, but they continue to have, so then what they basically say is there's a group of patients that have growth and then stability with treatment beyond progression. So they were growing, you continue the progression, and somehow no change, things have just stabilized. So that's just having a little bit of patience. And there are patients who potentially maybe were shrinking with stable disease, eventually having progression. But I think that's how we think about things, right? I'm going to treat beyond progression. Have I changed the kinetics in any meaningful way? If they were growing at a 25, 30, 40% rate from scan to scan, if I treat beyond progression, am I still at that same slope on my graph, or have I flattened the slope at all? I think of this often with tebentafusp uveal melanoma because of treatment beyond progression is certainly indicated there. Or have I continued and the slope is getting worse, it's getting steeper. So stabilizing or improving in that slope, I think, is helpful to think about. So it's thinking about the kinetics before and after. Anything you want to say about that, or is that sort of how you also think about it?
No, I think it's really important. And whenever, let's say if we're having a kind of weekly team meeting with the whole team and the juniors and the fellows and everything, and someone says, oh, someone's got some progression, I say, well, what was the what are the baseline sites of disease here? That's really important to understand what's happened in the interim, because otherwise, with all due respect, I don't think you can expect radiologists to go back through, we can't anyway, every scan from the start of treatment or even pre-treatment to get an idea of trajectory.
That's it.
Yeah, whereas we have to think about that. And it's important for patients because it might be that it's really a trivial amount of progression and straightforward to either not do anything about it at all, depending on where it is in the body.
Well, wouldn't you like some AI radiomics tool right here where you could basically feed in, well annotated, the AI can pick up tumor from non-tumor, and it can do exactly this. I've seen one company do this over the last 5 years maybe, but I haven't seen where it's gone, where basically, how you can take a slide and do multi-pixel, you can do multicolored immunofluorescence and then digitize it, right? So they'll basically take the human body and So they'll start digitizing the human body with color, and tumors will all sort of light up. So now you have maybe a coronal image on CT of somebody, and you just get a glance, okay, everything in yellow here is tumor, right? So then it's not so much about individual target lesions and are they growing or shrinking, but as so now target lesions are getting smaller, there might be some new tumor. Okay, so as you say, it's not reasonable for radiology to do lesion assessment metrics on everything, the targets, the non-targets, the new, and then do all the math here, right? And have to do they don't do the math, you have to do it, right? But what is kind of cool and very, very almost instinctual to see is when you have a coronal image of somebody and you see an amount of tumor, then you see it responding, then there's new tumor developing. You can instantly still look and say, but is that more yellow than I was seeing at baseline? Even if it's new tumors, or at progression in existing lesions, we touched on that briefly previously, you can almost instinctively quickly say, oh, that's more or less tumor than we started with, which feeds into this decision making. So anyway, I'd love to see some AI progress here.
Yeah, well, the technology exists already. I mean, that's not even in dispute, right? It's a question of actually getting the data sets together and overcoming all these hurdles for doing AI analysis. But you can imagine in an ideal world, which might not be in the too distant future, you actually look at this and you say, well, actually, there is this one area and we are going to do this. Or maybe if we could try to rationally target mechanisms of resistance, and this is kind of a fantasy at the moment, do a biopsy of that area and try, if we could, to understand why. Because that's the other problem about mechanisms of heterogeneity, let's call it, of mechanisms of resistance. I mean, I think they're going to be variable over space and time and actually difficult to study. So there is something in there for that as well. And I guess the final piece, and maybe this is the other big take-home message, and you've said it already, is that when you're looking at new approaches, new drugs in some sort of refractory population, no matter how you define it, even if you define it carefully, it has to be taken into account by carrying on the previous treatment beyond resist progression. There's going to be some sort of level of efficacy there. So I think this is important when one's looking at small, new, non-randomized data sets, when one's talking to often small biotech companies with their new molecule, and we're seeing some evidence of efficacy. I mean, I always say, and I have done for a while, actually remember that there could be something kind of residual from the previous treatment. So I think the authors make that point, and I would agree with it.
And I think now with a large data set like this, we actually can potentially quantify that somewhere between maybe 8-10% RECIST, 25% clinical benefit is just carrying on that treatment beyond progression. So the cautionary tale here, I think that we're saying, to put a real fine point on it, the cautionary tale is you run a phase 1 and you see something like a 20% response rate in the PD-1 experienced setting. You do not jump straight to a phase 3. You enrich that.
No.
You take on more patients. Perhaps you go to a randomized phase 2. I know we're talking finances here, but you got to be so careful seeing a 20-25% response rate in PD-1 experienced melanoma and saying we go right to a phase 3 based on that. We've seen it time and again. We haven't done our series of negative trials here, but we're going to. But we see it.
Yeah, and I mean, I think this is an uncontroversial point, certainly amongst academics, that the importance of doing randomized phase 2 trials in this and other settings. It's formally not comparative, but actually it gives you a sense of this, and actually it's a relatively quick and easy thing to do, certainly in the context of a negative phase 3 trial.
You need me to pause so you can get the phone?
No, I'll get that in a minute.
Okay.
It's gone.
No, but I actually hope that that point is well made. And for any venture capitalists or financiers, this is why you can't pressure, small biotechs to just go from boom to boom. There is a little bit of stepwise progression here. There is a little bit of spend here, but you will save yourself the spend of a phase 3 trial if a well done randomized phase 2 actually shows that signal doesn't pan out. So you either keep enriching that phase. I just think it's a point to be made, because we've now had this experience a few times with some great large companies, but also some smaller ones. I think we have to be careful.
Yeah. Okay. Then maybe that's a nice place to end. We've had the clinical discussion about how we talk to patients about this, but also there's a bigger issue here as well for doing trials. So very good.
Okay. Good. Thanks.
Bye.